So the background is, I think here, is that we all know that iron is necessary for the normal function of cells. But if there's too much iron in the wrong place, it's harmful. And the point is worth mentioning here is that it isn't always a straight relationship between one measure of iron overload and another, and a relationship between one measure and harm. So, for example, you can have a lot of iron in the liver and not in the heart, and vice versa. And in conditions such as superficial siderosis, where you get iron in the central nervous system, it accumulates there, but where the iron in the rest of the body is normal, but it causes an enormous amount of harm. So uncoordinated iron in the wrong place is harmful. We want, in the context of thalassemia, to estimate iron so that we don't overtreat and we don't undertreat. Now, actually, overtreating has been an issue right back to the 1970s. So when Desra was first introduced, people had problems with their vision and their hearing because of overtreatment. And we worked out an algorithm to minimize that. And it's now fairly well established what you need to do, and you don't need to monitor quite so closely. But with XJADE now, we need algorithms, and we need to monitor patients so that we don't give too much treatment. And it's not as simple as it seems. So high storage iron, just to reiterate, in tissues is linked to the risk of complications, and low storage iron increases the risk of toxicity or with overtreatment from chelators, or at least some chelators overtreatment. And so for treating, we're talking about transfusion-dependent thalassemia at the moment. There are simple things we can do without having expensive MRI monitoring. We can look at the iron loading rate. We can just tot up how much blood someone's had. And quite often, if a spleen is getting bigger or patients are storing red cells at an increased rate, then the consumption can creep up. And it's important to monitor that in the clinic so that we know when people are getting more transfusions. The patients will often notice that themselves. Serum ferritin, you've heard from George already. I'm going to expand a little bit on that. The liver iron concentration is going to be covered a lot in this seminar, as is myocardial iron. The other important thing is that organ function is really, really important. So if you've got someone with iron in the heart and the heart function is normal or high normal, you may be a little bit less concerned than if you've got the same situation and the ejection fraction is dropping. So that's one thing we can do. Endocrine assessment, growth, all the damage that we know occurs from iron overload needs to be monitored carefully. Some of these things are reversible, such as left ventricular ejection fraction. Some are broadly not, although some people do get some degree of reversibility. Once the endocrine damage has occurred, you don't get a lot of reversal. And the other thing we monitor very carefully in the clinic is adherence. And actually, we use things like the serum ferritin and the liver iron measurements to give us a clue whether adherence is the problem. It's very unlikely that an iron chelator which has worked previously stops working for a chemical reason, a biochemical reason. It's almost certainly due to be either increased transfusional input or decreased adherence. So let's talk about ferritin. You heard from George a bit there. We can use it to monitor response to iron overload therapy. Venous section inoculation. So in hemochromatosis, we have fairly clear outlines of how we use it, but there are issues there which I'll touch on. The positive features of using ferritin is it's actually a very well-validated test against international standards. There are international standards for ferritin. It's convenient in the clinic, so when the patient comes for transfusion, if you can afford to do the measurements, then it can be done there. It's very useful for assessing trends. So whereas a liver iron measurement may be done once or maybe twice, maximum a year, the ferritin you can do every 3 months or so. And so you can early detect trends. And we know actually from old data that survival and complications, although in individual patients is challenging sometimes, in populations as a whole, there's a clear relationship between the control of ferritin and outcome. The limitations that the serum ferritin is raised by factors other than iron. Fatty liver, in hemochromatosis, genetic hemochromatosis, which we see a lot in the UK, we get referred a lot of people with high ferritin, and it turns out they don't have high iron. They have fatty liver. They're overweight, basically. Or they have inflammation, or they have infection. The other big problem with ferritin is that once the levels get high, above, say, 3,000 to 4,000, there's a lot of noise in the system, and it's very difficult to detect early trends, which are much easier to detect at lower levels. And as a one-trick pony, it's not really going to identify your what situation with iron in the heart is. If someone's had a very high ferritin, which we know is not due to fatty liver or inflammation, let us say we've done the appropriate testing, so they've had very uncontrolled high ferritins for a long time, they're going to be at very high risk of heart disease. What are the targets with ferritin? Well, in other forms of iron overload, such as genetic hemochromatosis, we know that if a patient has ever had a ferritin above 1,000, they have a lifetime increased risk of fibrosis and cirrhosis. So even when you get the ferritins down to 50, which is the target, they retain an increased risk of hepatocellular carcinoma for a lifetime. And people forget that. In thalassemia major, sustained levels above 2,500 are thought to lead to an increased risk of heart disease. There's quite a few papers historically which show that. And we know that low levels in the context of standard doses of chelator are associated with increased toxicity. So with desferal, we get increased risk of neurotoxicity. And in XJADE, we see increased risk of renal problems in people who've got low ferritins. And we've seen a lot of people who've got fatty liver or inflamed liver where the ferritin doesn't come down as much as you think it might. So you actually end up over-treating patients with XJADE and you get proteinuria or increased creatinine. So the target levels are different for different diseases. So for example, in genetic hemochromatosis, we're aiming for less than 50 micrograms per litre, whereas guidelines for what they're worth, and we can discuss what they are worth, are to keep the ferritin less than 1,000 in transfusion-dependent patients when you're treating with desferal, probably less, and we can get down to 500 or less with deferrosarax, provided we're following the problems with renal problems if we overtreat. So why don't we just use ferritin? And this is really highly relevant to the world situation. If you just use ferritin, what would you lose? Well, we know pretty well that a lot of the really good outcomes that we are seeing in the UK and other countries relates to the ability to tailor treatment to an individual. So we can have broad policies, which are great, but we do need to tailor for the individual. And we know that the variability in ferritin only accounts for about 50% of variability in liver iron, and that's at standard levels. It's even more variable at high levels of iron load. This is old data showing that controlling ferritin does have a prognostic significance. If you don't control ferritin over a long period of time, as a population, you have increased risk of cardiac death. Yeah, I'm sorry, I'm advancing here and you're following me. Can we go one more forward, please? One more forward, please. One more forward, please. So this is showing a relationship between ferritin and liver iron when the ferritin's less than 4,000. It's quite a tight relationship, and that's why following trends in ferritin can be useful. Now, just advance. Next button, please. And then you can see how that relationship is when the ferritin's above 4,000. You can see it's a very fuzzy relationship. So controlling treatment when the ferritin's very high can be challenging. And next slide. There you see the correlation. It's quite different. Next slide. Next, advance, please. Okay. There we have the relationship between liver iron. Now this is trends. So what we're interested in the clinic is following trends. You see a patient sequentially, you see them 3 months ago, you're seeing them now. Let's say the ferritin goes down or it goes up. How much, what does it mean? Well, when the ferritin's really high, it's very difficult to know if you're making headway. It becomes apparent, but it's very difficult in the short term. So that's when the ferritin's above 4,000, very fuzzy relationship in the trend. And next slide. And when the ferritin's less than 4,000, that's a much clearer and cleaner relationship. So it's much easier in the clinic to use the ferritin to guide. But of course, it's not perfect. Next slide. So because of these problems with ferritin, people use liver iron measurements. Why do we do that? Well, we know not only does it give a better prediction of a body iron than a ferritin does, but also we know how it relates to pathology. So that if we keep the liver iron less than 7, for example, all the time, the risk of fibrosis in the liver is very low in hemochromatosis, for example. And we know that in thalassemia, if the liver iron is above about 15, then the risk of heart disease goes up, as does the risk of fibrosis progression. So we know how liver iron relates to pathology in the broadest sense. Next slide. Next slide, please. So this is going to be covered in subsequent talks, but of course we have the liver biopsy was the way things used to be done. There is the SQUID method, which is only used in about 3 centers in the world, and you have the various different MRI techniques, which I think Tim is going to cover quite a lot. Next slide, please. Why don't we just measure the liver iron and the ferritin? Well, the obvious reason is because although there are some principles relating those to the risk of heart disease, it's, again, a fuzzy relationship. Next slide. Next slide, please. Okay, so biopsies, when I first started looking after thalassemia, were used much more commonly than they are today. It does actually tell you some useful stuff about fibrosis and cirrhosis and so on. There's a lot you can now tell by doing fibroscans and so on, but there are occasions when biopsy is essential. The various MRI techniques came in much more recently, and I'll leave that to others to describe in detail. Next slide, please. Next slide, next slide. So this is the biopsy. You need to get a big piece of liver to get proper representative sampling, and it has risks associated with it. It's unpopular, and we don't do it a great deal now. Next slide. Next slide. I'm going to speed up a little now. This is another thing to say that when we know that when liver iron is high, it puts the liver enzymes up. So we can measure the liver iron by MRI, and we know when the liver iron is very high, we get an artificially raised ALT, well, not artificially, but a secondarily raised liver function. Next slide. And I'm going to go to the next slide. I think Tim will cover this. This is a study we did relating biopsy to liver iron measurement by various MRI techniques and related to the literature. And they all correlate, but they don't give the same answer. So that if you're using a different MRI technique, you could get a different value. So for example, if the patient has a value done in London and then goes to Rome, you may not get the same answer. And if they go to Mumbai, you may get a different answer. So, you know, if we all spoke the same language, it would be helpful as in life in general. Next slide. Next slide. So you'll see this slide, I think, several times in subsequent talks. This is important because it shows how survival relates to iron measurements in the heart. Now, in many diseases, such as hemochromatosis or even non-transfusion dependent thalassemia, the risk of iron load in the heart is so low that we tend not to measure it obsessionally. We may do it once and then never again. But once there is iron in the heart, of course, we need to follow levels with time because, as you can see here, survival relates to levels of iron in the heart as measured by T2 star. Next slide. And when we introduce cardiac T2 star measurements by MRI to the clinic at the Whittington and UCH, in the cohorts we looked at, we saw really it's the same data that George showed, but it's shown a slightly different way, that survival related to control of T2 star. And once you know the patients who've got more iron in the heart, you can target them, you can intensify the treatment. So you don't just carry on doing what you were doing before. Next slide. I've covered this already, so I'll go to the next slide. And I've also covered this already. I think we go to the last slide. So what about the future? I think while the science of iron overload and its monitoring and its treatment are pretty well defined, the implementation of that knowledge is very patchy and uneven, both nationally in the UK even, and globally. And this is really the topic of this meeting, I suppose, is to try and apply that knowledge to a more appropriate distribution of treatment and diagnosis across the globe. Why is that so variable? Well, perceived costs and organizational issues. Now, my personal view is that the costs of monitoring are not that expensive when you think of the global costs of transfusion, when you think of the global costs of chelation. It's not that much. The main cost is buying time on an MRI machine to monitor the patients. That's the main challenge internationally. And these are organizational issues to some extent. How do we make MRI available to more patients? And how do we make sure that the MRI that is offered is to the appropriate regulatory requirements? Patient representation and advocacy is absolutely key to this. If patients realize that they're paying for tests which are not to a standard that is required, then they can advocate, and they do, I mean, but I think we can do better. Is there a role of pharma in this? Now, when Novartis were developing XJ, they became interested in this, but of course, then they're not involved directly now, and we're using generic drugs. So how can we use pharma or the costs of drugs that are all being paid for to improve monitoring? I think this is an interesting discussion we can have later. And are there other models we can use to decrease MRI costs? And I know that Tim has thought about this quite a bit, and quite a few of the people on the panels today. So I think these are the particular challenges for the future. The science is there, but the organization and the remuneration is not always there in all countries. Thank you.